Hello, everyone, and welcome to another episode of Public Health Musings. I'm your host, Dr. Caroline Kingori, a faculty member at Ohio University. I'm so glad you could join us today. Please remember to subscribe to the audio podcast wherever you listen to it, and also the YouTube page. So today we have a treat. I'm so excited to be joined by my colleague, Dr. Melissa Thomas, who's an assistant professor in the Department of Primary Care at the Ohio University Heritage College of Osteopathic Medicine in our Athens campus. She has worked on addressing health disparities through community-engaged research and outreach models for over 20 years, with a specific emphasis in rural and Appalachia, Ohio, which is where she was born and still lives. And she has established a community-led nonprofit organization called the Center for Appalachia Research in Cancer Education to provide a framework to guide what she does in research. She also works with the Amish and Mennonites. They have a breast health project that she founded called Project Hoffnung, which is hope in German. And she'll tell us more about that and how she came up with that, and has served over 7,500 Amish and Mennonite women over a period of 24 years with women health care services in some of their underserved communities. It's now a multi-state initiative, and it continues to reach two of the world's largest Amish settlements. She also has trained numerous healthcare workers in those communities, and her key focus areas include reducing the burden of cancer through culturally competent education and addressing social determinants of health. Welcome to the show, Dr. Thomas. I'm so glad to have you on the show today.
Thank you so much, Dr. Kingori. It's a pleasure to be here and excited to be part of this podcast.
So you've done some really compelling and amazing work, and I just want to know, what's your story, Dr. Thomas? How did you get here? What does your journey look like? Could you give us a glimpse on that?
Sure. I think, as you mentioned, I was born, raised, and I still call Appalachia, Ohio, my home. And growing up right down here on the Ohio River, I grew up in a family that had not experienced college. I was the first in my family to leave for college, but my hero in my life was my grandmother, my father's mother. And I used to joke I was a bit of a different child. I preferred studying to a lot of the other activities that my peers enjoyed, and my grandmother really understood that. And I was devastated when she was diagnosed with cancer when I was just a little girl, and a cancer that could have been prevented had she had access to quality healthcare and education services. And so she suffered for many years with the disease and died when I was only 14 years old. So this is I knew at an early age what I wanted to make sure that her death was not in vain. And I wasn't sure what path to take to do that, but I was very dedicated to want to leave and go to college and do something with my life that put some meaning behind that. And after a series of, education opportunities, I stumbled across public health, and I felt like that was absolutely my calling. That what an amazing opportunity to work in an environment where we could be part of a process to help prevent and detect disease early, especially those diseases that had that opportunity to be prevented. And so I spent actually 20 years in healthcare within a healthcare system, working on a number of different grants and also working within that corporate healthcare environment, which eventually led me to an opportunity here at OUHCOM, where I serve as an assistant professor and have the last 4.5 years, and truly feel like I've found my calling in an area where I have an opportunity to work with other faculty and researchers and staff, and especially communities, all working on that same mission, which is really to empower communities with the tools to take charge of their health.
Wow, such a compelling story. And it's amazing just what you've accomplished over 2 decades, So I mentioned that your expertise varies across various health-related activities in rural Appalachia communities, cancer, health disparities, community-engaged research, women's health, so much more. So talk to us a little bit about your research trajectory.
Sure. I never would have thought we're getting ready to celebrate our 25th anniversary of work within Amish and Mennonite communities in the fight against breast cancer. And I would have never dreamt again, 25 years later, we'd still be working on this project. But really, my research trajectory started back when I was just in my 20s and had gotten my first job outside of the American Cancer Society, working at Riverside Hospital on a grant, again, that was funded by the National Cancer Institute, looking at the cancer disparities in the Appalachia region of the United States. And we partnered, the main grantor was West Virginia University, but Riverside Hospital was in charge of our Appalachia counties. And so we were working in communities and providing access to breast cancer screening services. And at that time, breast cancer was a big topic and focus. And so we were setting up mobile mammography clinics outside in these rural regions of our state, especially in counties that didn't have hospital systems. And I happened to attend one of those events and noticed that I was driving by some Amish homes, but that the Amish didn't participate in the program. And I simply just wondered why. And the local community members told me that the Amish didn't believe in healthcare, so there was no need to ask. And I thought to myself, well, shouldn't we ask them what they would like to do and what they would like to know? And again, I was only 20 some years old. I had, just a undergraduate degrees. I was always interested in research, but really didn't have a lot of that focus. But there was a grant that was actually funded in part through Avon, the Avon cosmetic products. And it was a $50,000 grant. And I had a local nurse who had arranged for a meeting with some of the Amish women in that area, because I didn't know anybody Amish. I had not grown up in those communities. And I asked them if they were interested in learning more about breast cancer, and they said they were. And that really started, this 25-year path. And it was through that project that we learned that nobody had explored these issues of cancer in the Amish and Mennonite communities, which I found interesting because now we have 31 states in the United States that have Amish populations. And Ohio is home to two of the world's largest Amish settlements. But it really stemmed from that question of just asking why. And it was through that opportunity I was funded through two other large national research grants that for the first time estimated breast cancer incidence and mortality rates. And we were shocked early on to discover that Amish women and those two large Amish settlements here in Ohio were dying at much higher rates of breast cancer compared to white women in the same counties and state national averages. And not because they were being diagnosed at late stage. Many women were diagnosed rather young and diagnosed with localized breast cancer, but dead within 5 years. And that really begged the question of why. And so we engaged then in a 20-some year project in looking at a 4-pronged approach to helping answer that question. And knowing that there had never before been developed any culturally appropriate breast cancer information for Amish and Mennonite communities that we've developed and established and tested. And in addition to that, we knew that we were so focused on educating Amish and Mennonite communities that we realized that many healthcare systems had a lot of misinformation and really biases and prejudice against Amish community members. And so we then established culturally competent healthcare programs that we delivered to agencies. We couldn't rule out some genetic predisposition to breast cancer as well. And part of our research is continued to center in that area. So, I think through this period of time, we realized that this has been a multi-decade study that really stemmed from that basic question of why. And I think to answer your question in all those areas of research, that's really been the heart of what I do is that, I used to say that what I do isn't rocket science. I just ask the questions nobody else is answering to communities that often seldom get their voices heard. And what responsibility we have to lift up those answers and be able then to share that information and empower communities again with those tools to take care of their own health.
That's amazing. And just to piggyback off of that and ask, how did you go about engaging them? Community engaged research now is at the heart of public health. We talk about community participatory research. We throw around that word a lot. But you had this community that really was neglected for a long time. So how did you engage them in this process? You said you asked them that question. Was it that easy to say, would you want to learn about, breast cancer, breast health? And they said, yes. And then that was it. How did you do that?
Right. And I know this is an area that you know quite a bit about yourself as well, Dr. Kingori. And, initially, I really did. I thought it was common sense. I didn't know that there was any science behind it or strategy. And I think I found after we were getting ready to publish some of our and share some of the results of our research studies, I found that many individuals, when I would wait for questions and answers, they weren't asking me about my research. They were asking me more about, how did you get into this community? How did that work? And so that really became I think what we realized was there really is a strategy involved with this. And we really I try to make that distinction. We talk a lot about community engaged research, and that topic's used a lot and often not correctly. And I think there's a distinction made too between community engagement and community-led research, and especially in communities that aren't used to playing specifically those type of leadership roles. I think for us, what was really important, and having that initial experience with the National Cancer Institute funding, one of the great mentors in our work was Dr. Gil Frindell from the University of Kentucky, who used to say that not only do the problems, but the solutions lie within the community. And I think it's been very important to make that distinction that I'm not Amish. I don't represent that community. And I think it's very important to make sure that I'm happy to talk about the work I've done and our best practices in working with the communities, but I feel strongly that I don't have a right to talk to you about who they are because I don't represent that community. And so we've really tried to make that as a cornerstone of the work that we've done. And I think that's why the program has been successful to an extent, is that, we make sure that it's the community's voices that are heard. So much so, again, as you mentioned, I helped establish a nonprofit organization. The acronym is CARE. So again, we had an infrastructure so that the community could take a leadership role in how we move forward with these projects. So no matter what grant that I received, no matter what project that we were on, we didn't just have an advisory board. We just didn't have an interested group of community members that I went and talked to when needed on certain projects or needed letters of support. We had full engagement from community members throughout this project, whether they were leaders or women in the community that had those voices. In addition to that, I made sure that we trained Amish and Mennonite women who were interested in serving as community health workers so that they were the voices on our project and could take that leadership role within the work that we're doing. And I think so often, especially in academia, it's exciting being the leader. It's exciting being the big dog. It's exciting being famous for something that you've done. And I think I've really tried to change that attitude that, when I went to meetings and programs about the Amish project, people didn't want to hear from me. They wanted to hear from Linda, the Mennonite community health worker. They wanted to hear from Ella, the breast cancer survivor. This program meant so much more that their voices could be heard, not mine. And I think in being able to share that decision-making and share that leadership role with community members really made that distinction, I think, in how this program worked.
That's good. I think it's always great when we can provide that inside story, it's not an easy process of trying to convince people to change their behaviors or to be interested in health issues that we think are important. They have other things that they think are a priority. And I think it's amazing that you were able to partner with them and they were able to trust you because at the end of the day, that's the main thing, that they trust that what you're doing is something that's, going to enrich them and help their communities. So what is the burden of cancer in the Amish and Mennonite communities? What do we need to know about the opportunities and the gaps in those communities where cancer is concerned?
Sure. It's it's an interesting question to ask and to answer, because as you know, most of our research about the burden of cancer in any population is mostly based on census data. So we know that our respective states have tumor registries and usually have a cancer surveillance and incidence surveillance system. We also know within our own states that we have a vital statistics database that lets us know who has died of certain cancers. But those tools are only as helpful as the census data that we have from these populations. And Amish affiliation is not listed as one of those religious affiliations within the census. So to give you an idea, when we embarked on this epidemiological study about breast cancer, again, Ohio knew who was diagnosed with breast cancer and who died of it, but Ohio didn't know who was Amish. And so there are directories with names of every Amish member. And, we're talking about, settlements that, for example, the Holmes County settlement, which is either the first or second world's largest Amish settlement, depending on the year. And, we're talking about, upwards of up to 50,000 names in this directory with over 200 and some separate church districts. And the church districts work independently of one another. So it's not like there's an overarching board where I can ask for a blessing or permission. We literally needed the blessing of 200 and some separate church districts to do this work. But it was a painstaking effort of case matching over 19,000 records over an 8-year period. So I knew who was Amish, and the Ohio Department of Health knew who who had cancer. So we had to link those records. It was a multi-year process. So we don't have a lot of data. There's been some preliminary studies where we've done random samples of populations within the community. And some studies have indicated that the Amish typically have lower cancer incidence rates in certain cases because of a more healthy lifestyle, due to exercise or due to diet and other lifestyle factors, including, less likely to consume tobacco or use tobacco and other related issues. But we still don't know all the answers to that. And again, while our study also showed lower incidence rates of breast cancer in Amish women, we also know that part of that was due to lower screening rates. And incidence tools often are only as good as the screening accessibility that we have of these certain screening, tests. So, often we felt in doing our work, we were going to increase incidence rates because we were going to detect it. But it was really those mortality rates that were a concern to us. And in fact, again, there were fewer competing factors like tobacco, like car accidents and drug and alcohol, substance use disorder, for example, in some of these populations. But it was shocking to us that in our study, which has been conducted several years ago, but the leading cause of death of Amish women under the age of 60 was breast cancer. And these are shocking numbers when compared to the same population group and ages. And again, that was really trying to discover the why behind that. And that's really been what our work has done. So it's not an easy answer. We've done some, again, the studies as best as people have done, where they've done random samples of looking at cancer prevalence and more self-reported data within communities. But, and again, in many cases, we are seeing lower incidence rates of certain cancers, but we still have a lot more to answer in that area. I think another interesting aspect is that almost all of Amish communities, all of them are rural areas. And many of the communities here in Ohio are in the Appalachia region or just north of the Appalachia region, where we also know that other disparities exist and certain social determinants of health or factors that do have an impact in higher cancer incidence and mortality rates among residents in these regions that, as we well know, have a lot to do with those social determinants of health. So, coupled with that and some of the other cultural aspects related to this community, we do see this as a need that desperately needs addressed.
Amazing. So we know that with the social determinants of health, we're thinking about where people work, play, live, all those factors play a role. You alluded to the genetic connection, but I wanted you to talk a little bit about culture. And what have you found is the relationship between the Amish and Mennonites culture and, whether it's breast health or health in general? What do you see as a link? And how best can we incorporate this cultural perspectives in our initiatives as we work with such communities?
Yes, it's another great question. And I've been blessed, especially with my previous work too within the healthcare system. I've led several initiatives. Most of my work has been in Amish and Mennonite communities in rural areas, but I also led a similar breast cancer project with the Latina community in Central Ohio. As well, I've done a number of research studies in the LGBTQ plus community. And I think what's been interesting in working with all these diverse population groups is, we often separate our communities that we serve, whether by need of grant funding or by need of reporting. And that's very important to do to understand some of the unique characteristics and issues facing communities. But I often think it's unfortunate we don't take time to collectively come back and talk about some of the similarities across cultures. And I will say across any population group I've worked that, one of those similar themes is that any community, wherever I've worked, they've all wanted the same thing. They've wanted to be treated with dignity and respect within healthcare or otherwise. And they wanted to know that they had options in what they wanted to do. And I think that like other population groups, the Amish they're a curious enough population. We know they exist. They remain very separate for their own religious beliefs from the outside world, from the modern world. And so they're a curiosity, especially here in Ohio, since they are located so much around our state. But there's a lot of stereotypes and misperceptions about the community that I strongly feel has negatively impacted their health, their quality of health care. And even more interesting, back in 2011, we saw this influx of these new reality TV shows and docudramas that were actually, supported by some pretty reputable, TV stations and channel networks like the Discovery Channel. So soon we were seeing shows called Amish Out of Order and Amish Mafia that were depicting these falsehoods about the community. And sadly, though, people really believe these things. And we saw, again, how that type of the cultural, phenomenon was impacting community. We heard from our own, Amish community colleagues and friends and members that, many of these Amish communities are tourist attractions and they appreciate that tourism. But we saw in the last several years that people would travel to these places and go on these roads where many of the Amish families lived. And we heard stories of Amish families saying that people would get out of their cars, like this was Epcot, and get out and walk into the yards of families in their gardens and take photographs of them like this was some exhibit and not their real lives. And we even noticed a shift in even some of the questions that we had at some of our events. And this was very bothersome to us, troubling in many ways. And we often said, too, that sometimes the group of people who know the very least about the Amish are those who live right on the perimeter. They don't know what they don't know, so to speak. And we did a lot of work in trying to understand that. I know that through the years we attended several diversity training programs or cultural competency programs about the Amish that were often led by someone who was formerly a member of the community or claimed to be an expert who really was not a member of that community. And to us, those were very dangerous sessions. We were shocked to see some of the misinformation and disinformation shared about the beliefs or the cultures of the community that were directly negatively impacting their healthcare. And so we really developed a number of ways to combat that. And one of the first things we did is I used to host day-long Amish symposia where we would invite healthcare professionals to come in, and it was led by Amish and Mennonite community leaders and talked about that. And that grew. So then we started hosting a national biennial conference where we brought in best practices around the country of different healthcare issues and research, but then also only allowed the Amish and Mennonite community members to talk about what they wanted to know about, their community and their culture. And that was really a game changer. We saw a huge shift in how we felt how healthcare systems were changing, how they were providing care for communities. And that made a really big difference. I know it's a long answer to your question just about how culture impacts that. I mean, I think for us, what I've learned specifically, and you mentioned this a little bit, is that there is nothing more important than establishing that trust with any culture where you don't belong to that community. And in many cases, that took years to establish. I know it took us 13 years to reach some of the more remote communities up in far Northeast Ohio. And just because one church district accepted me didn't mean the next church district was going to. And we had to do that. And when we decided to do a statewide expansion of the program, I mean, that was really critical that we had members of the community that did that. I did lots of boots on the ground outreach, but we really relied on our Mennonite and Amish community health workers to make those connections in those areas to be able to do that. I mean, I think too, Dr. Kangori, there's, I think, again, there's a lot of curiosities about the culture and the way that the communities are treated. I have worked in every corner of the state in dozens and dozens and dozens of communities. And, I think if anything, one of the important cultural differences is just how much faith leads this community. And many other cultures can say that as well, right? Not just unique to the Amish and Mennonite communities, but faith plays a really big role in that. And power over their own decision making. I mean, oftentimes when we would start to make new connections in communities, one of the first questions they would ask is that, yes, we'd like to know more about breast cancer, and yes, we'd like to be screened, but if you find something, are you going to make us do something about it? Or are you going to make us go to this place or that place to get care? And that was never our intention, right? We made sure that those decisions were part of that process. And we had to do a lot of teaching to healthcare systems because there's sometimes a conflict between how we measure success within healthcare and how communities measure success. So we know that there's some great accreditation standard guidelines within cancer hospitals, right? That one of the measures and metrics is how soon between diagnosis to treatment is there in getting care. And hospital systems want to reduce that number. So often we found that the minute that a woman was diagnosed with breast cancer, hospital systems were quick to bring on their breast navigators and sign them up for surgery, sign them up for treatment. And many Amish women needed more time to think. They needed more time to pray. They needed more time to talk to family and make decisions about what they wanted to do about their health care. And often we had to work a lot with hospitals to make sure that understand we appreciate those accreditation guidelines, but this family just needs more time to make those decisions.
I really like that perspective you've provided. It was very extensive, and that's something that we need to understand going into all these communities when we are, proposing to help with enhancing their health outcomes. We look at COVID right now, and it's great that we have this sort of statewide and, federal-wide initiatives, but some things have been sort of lost in the murkiness of that, especially with such communities, Indigenous communities, racial ethnic communities, and rushing them into this decision-making process. They telling people, oh, you need to maintain 6 feet. How do people, such communities maintain 6 feet when they've lived with families for a long time? And we see this in Appalachia and in such communities. So what are your thoughts about that?
It's interesting you asked that. I know that just a year ago, I had received funding from the network of the National Library of Medicine to explore communication strategies about COVID-19 within Amish communities. And I had the blessing of the leadership and many of the bishops to do a project like this. And I mean, it was a really humbling experience because, many of the concerns that we see in this Appalachia region were concerns from the community members as well. And when we, I think a lot of times when we start telling communities what's best for them, it just doesn't go too well. And, our role again, as, just as we were with the breast cancer work, is that we just wanted to make sure that community members had the most up-to-date information so they could make their own informed decisions about what they wanted to do. And that was our biggest concern. But, we saw lots of differences and how, especially related to, how conservative particular an Amish community was and how they wanted to, to treat COVID and how they wanted to take protective measures. Again, we truly saw the devastating effects of the disinformation about COVID-19 in these communities, which was devastating to us. But you're also working with communities that, for the most part, are very insular. I mean, they just are. They're in a very small network of people not all communities. There are many other communities where many of the husbands and family members work outside the home, so they had much more exposure to COVID. But when you're working in a farming community where, you're just surrounded, as you said, by your family and every 2 weeks and you're surrounded by people, that risk is a little bit different than it is for other populations. And I don't know that necessarily we did the best job in tailoring that messaging for certain groups. I think the other important thing to mention too is that there are dozens and dozens and dozens of varieties of Amish and Mennonite communities, as there are for many cultures and communities. So I can talk to you about the experiences I've had here in Ohio with a diverse number of members, but it doesn't mean that it really reflects that entire community. And that's also a very dangerous thing I think we see right in public health, whether it's cancer or COVID or any other health issue. And I think, again, that's something we've tried to communicate is that be so leery of those who call themselves experts, especially those who claim to be this. I mean, one person cannot represent that entire culture. And we need to have that perspective in that framework. So, I can tell you about 12, 13 different stories of different Amish communities and how they've handled COVID or their thoughts about COVID. But that doesn't mean that we've really even touched the surface of what those unique issues might be within that particular family. And I think a lot of it has to do as well with just the unbelievable, I think as technology's advanced over these last 100 years, especially these last 20 years, and the discoveries that we had with genetic testing and the role of genetics and the technologies and medical advances, medicine's hard to understand. It's hard for me to understand as a non-clinician. And trying to translate that, I mean, it seems like, I joke about this, but I think it's magic that you and I can sit here in two different places on this earth and have this conversation with this technology. I have no idea how this technology works. And yet we're trying to explain to a culture how we're talking about. I mean, it does seem like magic, right? We're going to get this shot and it's going to somehow explain to our cells to fight this disease. It seems like something out of a storybook, and in many cases it has. So there's a challenge in that. And so much of it is based, again, back on trust and how we can establish those guidelines within those communities so that they do have those representatives they can trust to talk about these issues.
I really appreciate you pointing out how important it is for us to recognize that there's no one size fits all, and we say that so loosely, but we assume that just because they're Amish, then okay, they're the same people, because they're Latinos, they're Latinx, they're the same people. And it's very different. I have found the same thing in, my global health work. I'm, doing work in Kenya. I'm very familiar. But from community to community, you have to keep changing the strategies and allow, the community to lead the process. But we know how we have limitations, especially when you have funding, you have tenure process and you have to do things within a certain period of time, and people are not understanding why you're not publishing yet or you haven't finished analyzing your data, et cetera, et cetera. And that really, I think, backs up against us really completely understanding these communities, right?
I agree. And there is that, I acknowledge that pressure and that challenge sometimes within that work. I mean, I think that's why community engaged research, it is so difficult because it is so time consuming and it follows a different value set, I think, at times. And it is this vicious circle, right? So, my passion for getting grant funding is to address a need that the community has stated that they want, right? And that's great. But I also, and I know you have to feel this way. So many people do, especially I think those in healthcare, public health, positions. But of course I want tenure, but my driving force is working with communities, but I can't continue this work unless I have tenure. So, you're continuing that discussion. And I feel really blessed, to be at a university that so appreciates the importance of community engaged research. And I really, really mean that. I'm really excited to work at OUHCOM, but also throughout the OU community, the support that's been in really engaging in this type of work. Because you're right, it's a time consuming process. And I often argue, though, that if you really want the best outcomes, this is the only way to do it. And, the other messaging that I know, we share with the work that I do is that, the most dangerous thing that you can do is go into a community and get grant funding and recognize the need. And then, that grant only lasts 1 or 2 years and then you leave. And I've argued with many colleagues that if you don't have a sustainability plan, if you're not in it for the long haul, especially with communities of need, then don't do it. It's not, you're doing far more damage than you are good on a project like this. And, I go back to my own work. And 25 years ago, I was given a $50,000 grant funded by Avon. And that $50,000 uncovered this unbelievable, gap that we saw in our understanding about breast cancer in the Amish and Mennonite communities. And, additional grant funding uncovered even more of a need. And thanks to the support, we were able to continue that work. But once we uncovered the burden of breast cancer, and once we had research funding through National Komen to develop a culturally competent breast cancer education program, once we estimated those rates, then what? What do we do then? And I wasn't supported to do this work. This was something I was doing on my own, but I also knew that we had to continue this project. And I was very grateful for the local affiliates of Susan G. Komen for the Cure that funded so many of our grants throughout Ohio that provided that programmatic support to continue this work, to deliver those life-saving screening services that we had to Amish and Mennonite women. But you're right, it's a time-consuming process, and it doesn't always follow the same trajectory. And I've thought about that a lot. I just real quickly, a brief story, but I remember right after, again, I'm 20-some years old. I'm working at, at a large hospital in Columbus, and there's a lot of competition, as you all know, between hospital systems and cities. And we just got the news that we got, we were one of 10 funded grants in the country on this breast cancer research grant. So excited. The director of the Cancer Institute was so happy and a really big advocate for community work. And so he, of course, wanted the newspaper to publish a story about the grant and the great work that we were doing at the Cancer Institute, especially due to the competition in the area. And I remember going back to one of the Amish bishops who they lived in a community not far from Columbus. And I asked him, I said, listen, we got this big grant. I'm all excited. And my director wants to put an article in the paper. And what do you think about that? And I'll never forget, this really guided my whole work. And he said to me, Melissa, we get your papers too, right? And I have to ask you, if I read an article like that, and we had only known each other maybe a year or two, and he said, but I'd have to ask, did you get that grant to help us, or did you get it to help yourself? And that shaped everything. I remember going back to my director saying, I don't want this published. And, he honored that. And we knew that in some ways that self-promotion could be damaging in some level in terms of other opportunities. But, I'm very grateful that I always had that type of leadership support, that we had to do what was best for what the community's needs were. And that was not the time to sit with any self-promotion about the work that was taking place. Our job was to establish that trust within those communities to make sure we were really in it to help them.
That's a great story, because with those competing interests and knowing that, we have to put our work out there, the question is, how do you do that, But I appreciate that you said, no, this is about the community. They helped us get to this point, and so we're not going to make it about ourselves. And that's awesome and commendable. So outside of academia, you also worked with the state and local governments and the hospital. You were the founding director of the Office of Health Equity at one of the largest healthcare providers in the state. So tell us what you did and what is the role of that office currently within the context of the work that you've done? Because obviously here there's a huge link with the communities you work with and your fight for equity in health.
Yeah. When the hospital system decided to establish a research institute, it was very exciting. It's a large community-based hospital system, so research was never at the forefront of the work that was being conducted there. And I was the first employee hired within that research institute. So it was very exciting. I was just wrapping up my PhD So I really felt like this was a great opportunity to, to further the education that I had to do this work and addressing health disparities in the state. And so that was really the impetus to move into that department. The chief medical officer had brought me on board to do this. And I was there for 10 years before leaving, coming here to OUHCOM. And it was in that time that, we were just establishing those guidelines and even how conducting research within an entire massive, large multi-hospital system over almost half the counties in the state. And I was ready to jump into addressing health disparities. My director at the time said, we really need some help in developing the infrastructure here and understanding how we even communicate to other clinicians, how we even conduct any type of research. So, I took a step back, and it was incredibly difficult, but it was such a learning experience for me to understand just the concept of research and grantsmanship. So I'm very grateful that I had that opportunity to help establish that infrastructure. But again, as my research interests continued to grow and opportunities to work with other communities and populations, I just felt like we needed to have a sign on the door that made sure that we knew that this was a place within this entire large, massive hospital system where there was an Office of Health Equity that could address the needs of the people we serve. And, I was really supportive for the leadership team that provided that infrastructure. And through the course of my time there, I continued to grow the staff. Granted, we had some specific projects related right to the Latina Breast Cancer Project and related, obviously in collaboration with our nonprofit, with the work with Amish and Mennonite communities and the work we did in Appalachia, established a lot of partnerships with government, with other institutions, with academic institutions, including Ohio University at the time. So that was very exciting. But I think that for me, what was just so important was that there was a place that I knew that there were other people within that hospital system that also was asking why. Why was this happening this way? And it was very exciting to be able to help, provide that messaging within our department in the Office of Health Equity to say, we want to be that source for you. So it was really rewarding to work with other clinicians who may not have had a strong research background, but, they wanted to understand what they, for example, there was a clinician who contacted me. They were just interested in understanding some of the disparities they saw in African-American women and treatment of breast cancer. And, it was a question that they didn't have any data, but they knew where to access the data, but they were really asking those hard questions. And I really admire the institution for, allowing that support of that work. And leaving was truly one of the hardest decisions that I had to make because I had such an amazing group of people with whom I had a chance to work. Again, as I said, moving up that corporate ladder, I was getting pulled further in administrative roles and away from my true calling, which was really in the community. So I was very grateful that before I left, I wanted to make sure, more importantly, that some of the team members, especially who represented some of the underserved communities in the Latina community, were supported. I wanted to move some of the grant-funded staff off grant funding to give them permanent roles within the system. And I'm really grateful to God that they were able to honor that, my request, before I left, so that, the staff are still functioning. So some of the work that we did under the Office of Health Equity has now been absorbed within some other departments, which makes me excited because a lot of the work was cancer. And so the cancer department absorbed some of that work. The director at the time has since retired, and they really did an overhaul of just what research means to the hospital system and have focused a lot on clinical research. But I'm very excited that some of the work that had been established at the time and some of those key community members that were brought on as grant-funded positions in my department are now permanent fixtures within that hospital system. And that, to me, is just a true success story of really valuing the work of the community members as experts in their own communities.
Yeah, and speaking of community members as experts in their own communities, you do train community health workers. And we know that they're really instrumental in public health and, among communities in general, especially in underserved and rural communities. So tell us a little bit more about what do we need to know about community health workers? What does that look like? And why are they so important in enhancing the health of our communities?
Sure. I know we talked a little bit about how, I think that, as I said, I feel I have a connection as part of the state growing up here and still living here in rural Appalachia, Ohio. And I understand that cultural context, but again, I didn't grow up Amish or Mennonite. And even after 25 years, I would not at all call myself an expert in the community and their beliefs. And so we needed, I knew the success of this program had to be that we needed to have women in the community who could share that messaging. Interestingly enough, Dr. Kingori, what we started out with a model that was that was a best practice at the time and still is that we want to do a train-the-trainer program where we train community members to go out and educate other community members about this issue. So that was our model, and I had gotten some large grant funding. And so there were a couple Amish women who came forward and we trained them to go out to be the breast educators of our new education program. And so we trained one woman and she would not go out and educate anybody. And we were devastated, didn't know why. What could we do? She was older and we thought maybe she just didn't feel comfortable doing that. So we panicked. And so we found another Amish woman. This is again like 1999 or something to that effect, many years ago. And we educated a younger woman who was actually closer to my age. And she still wouldn't go out and educate women. She loved the knowledge, but she wouldn't go out and educate. And so again, like you said, we had a grant to run. We had deliverables to meet and we weren't getting anyone educated. And finally, we talked to her and said, you're a member of the community, but I don't understand why you won't go and educate people. And finally, she confessed. She said, we really appreciate this information, but you're asking me to go out into my community and teach. And it makes me feel that I'm higher than everybody else in this community, that I'm, in a sense, more knowledgeable or better than they are. And I don't feel comfortable doing that. In fact, we don't want to be the educators. We want you to educate us. That's not what we want. So, and at the time, I wasn't even old enough to get a mammogram. So I didn't feel I could have that connection. So I actually hired my mother, and my mom is our key breast health educator. And at 76, she's still going strong and has been with the program from almost the very beginning. And my mother went back to school at Ohio University just a couple of years ago and went through the community health worker program and became a certified CHW. And I'm so excited for her that she had that opportunity. But I learned at that point, wow, there's, what an important message to have about what the community wanted and felt comfortable about. And they related to my mother. She grew up on a farm. She had many similar experiences than they did. My father didn't have electricity until he was, I think, 9 or 10 years old. So it was really a family affair at this point, right? So that also helped establish the trust that my family was out there doing this work with me. But I think that there are just some things culturally that I'm never going to understand. And these community members really do. And I'll tell you, one of the other really important distinctions that we made early on, one of the first grants, I think I mentioned, I received a national research grant from Susan G. Komen. That very first grant that I got, they awarded 10 grants, and we weren't one of the top 10 funded, but they came back. It was worse than a yes or no. They came back saying, we might have a little more money. You're next in line to get funded. Hold on just a few more months. And they did. Thankfully they funded 14. We were one of the 14 funded. But I was curious who got funded. And there was a program that was funded that was working with American Indian communities, Native American communities. And I wanted to know who this woman was who got funded. And her name was Dr. Linda Burhen-Stepanoff, or Dr. Linda B. She's a member of the Cherokee Nation. And I went to one of her presentations at the American Public Health Association. And Linda B. is such a life force and such an amazing advocate for the community, background in public health. But she became a mentor of mine. And so much of the work we did early on within the Amish community was based on a lot of the work that was done within the Native American communities. But Linda B. taught me something very important. And she said, when you hire your community members, you pay them and you pay them well. And I remember her saying, why would it be that you would pay somebody with a master's degree or with a college degree more than you would pay for the one person in the community who's the expert that's knows so much more than anybody else? Whenever you submit a grant, you pay your community health workers the same amount you pay anybody else. And I've done that, Dr. Kingori. And I know I had to work a lot of times with grantors saying that, and everybody knew that on the program. It was very transparent. I appreciate you with your master's degree coming in as our program manager, but and they were paid well. But I do want you to know that this woman here with an 8th grade education, who's the community health worker expert, she'll be paid the same amount of money as you because, she's also an equal right. And I think that equity in salary, that equity in who had a place at the table, it made a huge difference. We weren't just saying it on paper. I mean, they really did run the programs. And I'm very grateful that, I just want to give thanks. Linda Nisley has been with our program for years. She's a Mennonite certified community health worker. And Linda was instrumental in expanding the program. And, she really had to go outside her comfort zone. People wanted to interview us. They wanted to interview me to talk about programs. I didn't want to be interviewed. I wanted Linda to be interviewed. So we worked very hard at giving her those tools to make sure that she felt comfortable in that role because she was the one to be the messenger. And to this day, I give so much credit to the Amish and Mennonite women who did have to go outside their comfort zones to play in roles that they normally would never have played, but knew it was important for their communities to be able to have that voice.
Amazing stories. I could listen to you all day, just, seeing all these nuances. Who would have thought that, we want to give them the tools, the skills, the knowledge, and then go back to the community and talk to them. But they also have this, self-efficacy issues, if you will. Absolutely. And the payment, never thought about that. I talk to my students all the time about the, just juxtaposition of formal education and that kind of knowledge that people have, especially, in my area with maternal and child health and traditional birth attendants and versus skilled birth attendants. But it's the traditional birth attendants that the community trusts. And so they need to be recognized. And yes, train them just like, community health workers and the other skilled birth attendants, but pay them accordingly, remunerate them accordingly. So, yeah. That's
absolutely.
Wonderful.
And also have them as co-investigators on your study. I'll say too, as well, that, Linda and this previous COVID study, I mean, we had members of the community who went through the IRB training that were listed as co-investigators on this study. I think, again, it's a way of showing that equity on these projects, that the community members who want to play that role play a very important equal part and equal ownership in the work that we're doing. And I think that's a really critical aspect of the work that we do.
Amazing. This is really great, but we're almost winding down. So if someone is interested in becoming a community health worker, what do they need to do? You talked about the training at Ohio University. What goes into that? How do they apply? And kudos to your mom, for
I know. Back to school. It was such a rewarding experience for her. And what an amazing gift for someone who didn't have the opportunity to go to college, that she has those initials behind her name. And in Ohio, we have a unique program. Ohio was one of the early adopters in certifying community health workers. And our program is actually certified through the Ohio Board of Nursing. And there are multiple places throughout the state now that have institutions that provide, formal training for community health workers. And they all are a little bit different in how they function. I know we're excited Ohio University has a formal community health worker training program. And so it's really helpful. But you can go on to the Ohio Board of Nursing's website and see a listing of all the institutions that have CHW programs. And so usually it's a combination of so many hours of education or training, and they all differ a little bit in how they function. But we have so many hours that are required of instruction. And then I think 120 hours, of actual hands-on training that you have to get under your belt, or an internship that's required of that time. And so once those requirements are met, you can apply for an application with a background check to the Ohio Board of Nursing and become certified. And just like any other certification, there's continuing education hours that are needed to keep up every so many years and reapplication. So it's a rewarding experience. And I think it's really important that we try. In fact, we have a member of the community right now who's just wrapping up her training through Ohio University's program as well, which we're very excited about. And I think it was also important because I play that role as community health worker that I also be certified. So I went through the training a few years ago to become a certified community health worker so that I understood that process as well. And I think that's been really, beneficial to have. But, we do encourage individuals to, check out, again, the Ohio Board of Nursing's website for opportunities. And there's currently right now several places within the state that are hiring certified community health workers on grant funding opportunities, not too far from Athens, actually in Jackson County. So we're seeing more and more opportunities for CHWs to be hired within healthcare systems, within the workplace. And I think that interest is still going to grow because we know of the success stories we've seen in having CHWs on that healthcare team.
Wonderful. So one last question. We know that sustainability is everything with the work that we do. And one way to ensure sustainability of these initiatives is developing policies. So what do you think are the policy implications of the work that you've been engaged in? Have you, participated in some of these policy decisions, et cetera?
Yep. Really another great question. We used to let our grantors know that, we had a unique sustainability plan, and that is we really wanted to run ourselves out of business, right? Like the role of our project was to bridge that gap between the culture of communities and the culture of healthcare. And the role is that, especially as a multi-state grant, there is that responsibility to make sure we want community members to go to their local respective areas. A lot of times health departments or hospital systems would contact us to say, we're struggling trying to reach these communities. Can you help us? And we felt honored to go in and help link those groups and be able to then simply walk away because that trust was established. And so our goal is that, again, we're not needed, that bridge has been built, and sometimes it has and sometimes it hasn't. I think there was a big shift for us. As I mentioned, so much of our funding was supported through the local affiliates of Susan G. Komen. And when the decision was made a few years ago to no longer offer grant funding to community-based organizations, it was really a devastating blow. And it really required us to start thinking again about what this program was going to look like. And I think what's been really exciting for us from a policy standpoint is that when we no longer had grant funding to support the screening structure itself, the screening services, I'm excited that due to the relationships we had to many hospital systems, we saw a shift in hospitals in providing more affordable screening mammograms in those areas. And I really do, I give a lot of credit to many of the local rural hospitals in doing that. But I think for us, it was very, very rewarding to see. We still partner with communities and offer, some areas we have grant funding to cover costs and others we don't. But, we started thinking more from a policy and system level. So when we couldn't provide the screenings, we did some really simple strategies. And I'd like to think some of these had a part in changing some of the infrastructure and again, some of the just the transparency of cost and the costs themselves. So when we couldn't provide the free screenings anymore, we did a simple thing. We called all the local hospitals and asked what the cost was to get a mammogram. And those costs range from, $150 to $800, $900. So, we have a very large distribution list now after 20 some years. And so we're sending out newsletters with a contact number and list where we're seeing hospitals charging $1,000 for a mammogram and others only charging 100 and some. I think it made a dramatic difference. We're only really reporting the facts, but we saw a massive shift, and especially in some of our hospital partners saying, what do you need? It's like, we need more affordable screening services. And I'm so excited to say that in some of these areas where we typically were providing screenings due to cost, in some of those areas, I'm happy to say we are no longer needed, that there's been a direct link to be able to provide affordable screening services within those areas. And that's really what this has always been about, where women could go into their communities to get the care that they need. And I think that's been a great success story, a painful one in seeing differences and shifting of funding streams and for the work that we're doing. But I think in many ways, it's been one of the most successful ways that we can make an impact, is seeing policy and system changes. We've also seen, and I don't get credit for this, the hospitals get credit, but, in light of the work we've done with our community members and community health workers, there's been some amazing leaders like Pomerene Hospital, for example, and other hospitals within Amish communities that are now hiring community advocates, that can speak the language, that are from the community, that are being hired by hospitals to do this work, to serve as that advocate representative for community members. And I think that's going to continue to grow. But it's wonderful to see, in many areas where these were services that we typically provided because there was no one else doing it, we can literally take a step back and look at other areas of need in communities because these services are being met.
That's amazing. I have really enjoyed talking to you and learning so much about your work. So interesting. And seeing the difference that you've made in these communities, and you've taught us about the importance of listening, importance of being there, shifting our priorities to ensure that the community feels like it's included. I've learned a lot and I've enjoyed speaking with you. And I just want to say thank you so much for coming on the show. And if people want to get in touch with you, how can they do that?
Yes, absolutely. Well, I'm located again at the Athens campus at Ohio University in the Heritage College of Osteopathic Medicine. So I'm easy to find on Ohio University's website in the School of Medicine. I'll also say if anyone's more interested in learning about our nonprofit and some of the other projects that we've done in the communities, you can always reach us at our nonprofit website, and that's www.applecare.org, and that's spelled APPALCARE.org. You can learn more about some of our other amazing projects, community-led initiatives like our photo book project, which is an amazing cultural book about the community that was written and photographed with the community. So the first of its kind, and some other upcoming initiatives. So we're excited to have people learn more about us as we celebrate our 25th anniversary this year. And again, a special thanks to you, Dr. Kingori, and this amazing podcast and sharing some of the works that we're doing in communities of need.
Indeed, this is public health. And so I want to thank the listeners and the people who will be watching this on YouTube, and to invite you to come back for more episodes. And thank you again for tuning into the show.